Good evening, everyone. Today I'm going to discuss about reuse. And first of all, thanks for Village sir. Thank you very much for introduction. And we know reuse will be a topic. It's a common topic, but it needs proper understanding and practices for reuse techniques. I'm moving on to the topic. First, what is reuse? Dialyzer reuse is a practice of using the same dialyzer for multiple dialysis treatments for the same patient. It's a safe and effective practice. I think in India, most of the dialysis centers are following the reuse dialyzers. And today we are trying to discuss why we are following reuse and how to do safe reuse and what are the chemicals used in reuse and how proper reuse techniques helps in reduction of infection in dialysis patients. First, before going to techniques, we first room, what is reuse room? In all dialysis centers, there is a reuse room is there. Dialyzer and blood tubings are washed in a separate room called reuse room. The reuse room shall be equipped with an exhaust fan. The reuse room shall have place for storage of disinfectants without contamination. And the RO water should be according to AAMI standard. For every reuse room, there are two different fittings to be needed for the water line. For a standard tubing to clean the blood compartment and the other one for Hansen connector for cleaning the dialysate compartment. This is the two Hansen connectors. And if these types Hansen connectors are not available, we can use the machines, the dialysis machines, venous or red or blue coupling for us Hansen connectors. The sinks used for reprocessing should have a depth of greater than 45 centimeter with a drainage mesh like this, a drainage mesh at a depth of around 20 centimeter to prevent dialysis and tubings rusting in the effluent. The earlier I told the AMI standards, there's a maximum concentration of contaminants. The electrolytes, this electrolyte should be this much amount only we have in RO water. The other in endotoxin unit and colony forming unit. For RO water, there is acceptable level. There is a less than 0.25 endotoxin unit per ml and a colony forming unit of less than 100 CFU per ml should be needed for a proper quality. RO water quality should maintain like this. As we all know, there are two types of reprocessing techniques. First one is manual and the second is automated. First we go through manual techniques. First one is labeling. Each patient's dialyzer is labeled with the patient's name, MRD number and date on which the dialyzer was taken and the number of reuses. This should be happen during the dialysis treatment. Before going to reuse room, the patient's name and MRD number should be written in dialyzer. Otherwise, so many new dialyzers are there taking for dialysis. We mixing with the this is a confusion. We have to discard the whole dialyzers. That's why during the dialysis treatment itself, we have to label the patient's name and MRD number and date under which the dialyzer was taken and reuses also. For number of reuses, how many uses, first, second or third, like that we have to write the number of reuses. The second one is rinsing after closing dialyzer, because while closing, we have to, blood should be returned with a sufficient amount of 0.9% normal saline. Air should not be, some centers we are closing with air saline method, but nowadays everybody is following normal saline method. Air should not enter the blood tubing or the dialyzer while returning the blood. The dialyzer and tubings are removed from the machine and carried out to the reprocessing area in a tray to avoid blood spills. It should be bring to the in a tray only, in a plastic tray we have to removed and carried to the reuse room. A pressurized rinse should be given to both blood and dialysate compartment with RO water. After that, the next step is cleaning. Fill the dialysate compartment with 1% hydrogen peroxide for 5 to 10 minutes. After that, connect the handstand connector to both the dialysate port and the water tap. And open the water tap, almost 15 to 20 psi pressure for 15 minutes. Cleaning is facilitated by reverse ultrafiltration from the dialysate to blood compartment. We are pushing water to dialysate compartment. From that, all blood should be clear. Reverse ultrafiltration continues until the effluent from the blood compartment is clear. If the header is removed to clear the clots, special care should be given to check the O-ring, and O-ring should be replaced properly. Improper placement of O-ring, if you forget to put O-ring replacement, results in blood spill when the dialyzer is used. And now all reusable dialyzers headers are openable. Then both the compartments of dialyzer are cleaned with RO water. The next one, checking test for dialyzer performance. How will check? There is a checking by fiber bundle volume. We are checking the dialyzer performance. It is measured by displacing the water in the blood compartment with air and measuring the volume. If fiber bundle volume is above 80% of the original volume, we can reuse the dialyzer. Yes, this is a video how we are checking fiber bundle volume. First, we fill the blood compartment with RO water and remove. Like this, remove all the air completely by tapping the dialyzer. Slowly, gently, we have to tap the dialyzer. Then all air should remove from the blood compartment. After that, we first one side of the dialyzer close with our thumb and remove the tubing from the other end. And connect a 50 cc syringe to the one end of the blood compartment, that's bottom end, and release the thumb from arterial. The other thumb will release. And aspirate the water slowly into the syringe. And we have to measure how much ml is there in. This is 50. Do not aspirate the water quickly, because slowly we have to aspirate. Continue the above procedure till the whole amount of fluid is come out. Next is calculation of FBV. After the FBV checking, we got a volume. That is the measured volume of water. How much ml we got from the blood compartment divided by priming volume of dialyzer into 100. That is the this is the formula we are used to check a fiber bundle volume. Dialysis should be discarded if FB is less than 80%. This is Fresenius. F5 priming volume is 63. F6 high performance series is 78 and F7 96. Different companies have different priming volume. The next, after checking a fiber bundle volume, if we are got more than 80%, we have to sterilize or disinfectant the dialyzer. Once clean, both the blood compartment and dialysate compartments are filled with disinfectants for 11 to 24 hours, because the renalin, we are filling renalin, 11 hours is needed. Formalin is filling means 24 hours is the dwell time hours to achieve effective sterilization. Final inspection. The dialyzer should not be used abnormal or overall brownish discoloration, or there are clots in the header, or several coated fibers are present. In visual inspection, we have to discard the dialyzer. The next is record keeping. The number of uses of dialyzer and fiber bundle volume should be noted in patient's record. And the name of the staff, who is the staff done reuse duty staff's name of the staff member also should noted in patient's record. And when the dialyzer is discarded, it should be recorded in we have a reuse register, and it should be recorded in reuse register. Then next is storage. Dialyzer or bed tubing shall be stored in steel polythene bags or plastic boxes with the covering with a lid in separate racks with patient name and MRD number. If so many patients have similar names, we have to write MRD correctly, and a name alert sticker should be placed on the top of the box, or in the rack there is a name alert, because so many patients have similar names. Then we have to take the dialyzer tubings for correct MRD and name. We have to double check with the MRD number. The next is, what are the advantages and disadvantages of dialyzer reuse? First, advantages. We know first main advantages of reuse is reduction in treatment cost. The dialyzer cost will reduced when we reusing. To chemicals. Some used in manufacture of new dialyzers. The third one is reduced intralytic symptoms like first use reactions. Nowadays it is rare because all companies are changed to heat sterilized dialyzers instead of ETO sterilized. Ethylene oxide gas causes first use reactions, but now all dialyzers are heat sterilized. And the next is reduced immune system activation and enhanced biocompatibility, because after every reuse there is a protein protein material is coated in the fibers, dialyzer fibers, that like that enhanced biocompatibility. Then waste disposal, less waste disposal. The disadvantage mainly is this is exposure to chemicals, both patient and staff, because we are not primed correctly or with the normal amount of saline, it will cause the chemicals is going to patient's bloodstream. And the staff also, while reusing, we are also exposed to chemicals in reuse room. And for formalin, if we are using formalin, there is if formalin is not washed out, there is a chance of formalin reaction. Formalin reaction means sudden, soon after starting dialysis, severe breathing difficulty and the warmth all over the body and severe pain on the venous returning needle. And that AVF and severe pain in the returning line. That's formalin reaction. And the next is blood leaks. If we are not using the appropriate concentration of hydrogen peroxide or chemicals, blood leaks can occur. Or we are forgot to put O-ring, or caps are not correctly fit, correctly not tight, the blood leaks can occur soon after starting the dialysis. And the pyrorenic reactions can happen by reuse, because our RO water quality is not adequate, or the our sterilization chemicals are not contaminated. The pyrogen reaction can happen. Then loss of dialyzer clearance. After each reuse, so many fibers are clotted with blood, and that's why dialyzer clearance is reduced after each treatment. The next is the major disadvantages. There is a chance of transmission of infectious agents from one dialyzer to other during reprocessing procedure. Thus, we are washing together. Or if one shift means that 20, 25 or 30 dialyzers, we are washing together. There's a chance of transmission of infectious agents like from one dialyzer to another. And the dissonant storage area is required. If we are reusing the dialyzer tubings, there is a separate room for reuse room is required, and there is a storage area also required for storing the whole tubings and dialyzer. The next is, what are the chemicals? Chemical disinfectants used for dialyzer reprocessing. The first one is formaldehyde. Formaldehyde is a colorless and has a irritating odor. As we know, it is a saturated solution of formaldehyde. 100% formalin solution contains 37 to 40% formaldehyde. It's commonly used as disinfectants and for preservation of biological specimens. This is the oldest agent for disinfection for reused dialyzers, and it does not degrade or change membrane properties. It's a low-cost solution, stable solution, but it is highly carcinogenic, and we know it is irritating to skin and eyes. spillage, any formal spillage occurs, we cannot stand near that because it is very irritating to eyes. It required dwell time is 24 hours. But usually it is nowadays nobody is using formaldehyde. It's an old sterilization agent. The next is hydrogen peroxide. 1% hydrogen peroxide we are using. It is very cheap and the best disinfectant. It is effective agent for removing blood from a dialyzer. It should not shall not remove the protein deposits from the dialyzer fibers, but it is irritant to skin and it should be stored in an airtight container. The dilution is hydrogen peroxide is we are getting 30% solution in 500 ml. So we have to dilute this hydrogen peroxide to our 1%. That is why I am for easy I am preparing in all chemicals in 20 liters. This is to prepare 20 liters of 1% hydrogen peroxide solution with 30% hydrogen peroxide concentrate. This is a dilution formula is there. C1V1 equals C2V2, where the C1 is the concentration of the reagent. That is the initial concentration. And the V1, that is we want to know how much volume you had to put that concentrate to make the solution, 1% solution. The C2 is the target concentration of the solution because we want 1% hydrogen peroxide. Then V2 is the total volume of the solution after dilution. I earlier told you that 20 liter for easy 20 liter we are preparing. The substituting these values in this formula, 30% into V1. That is the V1 is the volume. We want to know how much volume we have to fill. Equals 1% into 20 liter. From this, we got 666 ml. That is approximately 600 ml we got. Therefore, to prepare a 20 liters of 1% hydrogen peroxide solution, we have to add 600 ml hydrogen peroxide concentrate with 19.4 liters of RO water. We have to mix this two and put in a can, and we can dilute the clean the dialyzer compartment with this hydrogen peroxide. This is the formula, dilution formula, C1V1 equals C2V2. The next is renalin. Renalin is it contains peracetic acid 4%, acetic acid 10%, and hydrogen peroxide 21%. It's effective with all microorganisms such as bacterial, sporicidal, fungicidal. It's required dwell time only 11 hours. Its appropriate concentration we have to use is 4% when instilled into the dialyzer. For disinfectant dialyzer, we have to take 4% concentration. It's a cold sterilant and is glutaraldehyde free. It is effective against non-tuberculosis mycobacteria, HIV, and hepatitis viruses. It's non-carcinogenic. It is aldehyde and chloride free, no foul smell, and it is safe for patient and staff. And this is okay, less eye, nose, throat irritation while using. And so the next is how will you dilute renalin? Renalin, we all know this is comes with 100% renalin concentration. Is 4%, we want 4% renalin. The same dilution formula we are applying here also. C1V1 equals C2V2. C1 is the concentration of the original, that is 100%. And the V1 is the volume. We want to know how much volume we would record V1. And the target concentration is we want to get 4%. And the V2 is the total volume of the solution after dilution. That's 20 liter. And same we have done earlier, substituting 100 into V1 equals 4%. That's the target one into 20 liter. We got 800 ml. Therefore, to prepare a 20 liters of 1% renalin solution, we have to, not 1%, sorry, 4% renalin solution. We have to put 800 ml of renalin concentration to be added with 19.2 liters of RO water. This is 4%. The next is blood tubings reusing technique. The blood tubing must be like dialyzer. Blood tubings also must be correctly labeled with patient's name and MRD number. After disconnecting from the machine, blood tubing should be thoroughly rinsed with water. RO water is not needed. Actually, tap water also we can use for blood tubings. Make sure that all the blood clots are washed away. Check whether there are any clots in the arterial chamber, venous chamber, and pressure monitoring lines, infusion lines, and heparin lines. Then the clots in the arterial and venous tips. It's difficult to remove the clots in the tips. Should also be cleaned during washing. Otherwise, while starting, after priming, while starting only, we are noticed there is a blood clots in the tip. That's difficult to wipe with spirit saline. That is why when washing itself, we have to remove the clots in the arterial and venous tips of the tubings. Then the next step is fill the tubings with sodium hypochlorite 1% and keep for 15 minutes. And then wash with water for 10 to 15 minutes. After that, make sure all bleach is washed out. Wash the all the bleach is washed out. Fill the renal solution, same 4% renal solution and fill and store in a label rack. This is a bleach dilution of sodium hypochlorite. The same formula we are applying here also. C1V1 equals C2V2. There's a 5% bleach. Sometimes we have also got 10% bleach, but nowadays we are getting 5% bleach. This is a volume and the target concentration is 1% and the total volume of the solution after dilution is 20 liter. The same 5 into V1 equals 1% into 20 liter. That is V1 is equal to 4. We got 4 liter. Therefore, for preparing a 20 liters of 1% sodium hypochlorite solution, we have to add 4 liter of sodium hypochlorite from that 20 liter can and add it with the 16 liters of RO water. Then total 20 liter. Like this, we have to the both 3 hydrogen peroxide, renalin and sodium hypochlorite or bleach should dilute with like this. The next is personal safety. Ensure that while we are entering the reuse room, PP should be wear and eye protective wear should be worn during the reuse process because the chemicals should spill to the eyes and the gloves should wear, gloves, gown, everything should wear for our safety and make sure the sealing exhaust ducts are functioning. The next is automatic reprocessing system. For this, several types of automatic machines are available. It's safe, reliable and safe. Fully automatic processing and disinfectant cycles are going on there. It performs membrane pressure leak test. And it is very user-friendly and easy to operate. LCD touchscreen is there. And selectable programs for all types of dialysers. Total cell volume measurement and display reverse ultrafiltration cleaning is there. And only the disadvantage is needs high initial cost. This is 3 types. This is single station reprocessing machine. This is double station and this is multiple station machine. And next is how we do in automatic reprocessing procedure. The machine has already 3 connections. One is the RO water connection with Army standards. And the next is disinfection tube to the machine and other end to the disinfectant can. And third one is drain line. First, dialyzer repair steps. First, labeling is there like the manual procedure. First, we have to label the dialyzer before coming to machine. Switch on the machine, connect the dialyzer and select the model. And then select the station and start the process. Step 2, rinsing and cleaning. The machine itself, itself rinse and clean. While rinsing, the machine reverse ultrafiltration shall take place. The cleaning process begins with creating a vacuum in the mixing tank of the machine. The 300 ml 2.5% Renaclean or Renalin, something that chemical enters into the dialyzer. This solution shall be held in dialyzer for 4 seconds to break any blood clot. The third one is volume test. After cleaning, the setting is made as 80%. Our FBV percentage we are discarding is 80% for the dialyzer volume. If the actual volume is less than the setting, the machine indicates the failed status. The machine will tell the failed. And the next is pressure test. 350 mm Hg pressure generated by the air pump is supplied to the blood compartment of dialysers. Hold the pressure for checking any leaks. The machine itself check any leaks is there in dialyzer. The next step is affusion test. That's 200 ml of 3.5% Renaclin solution is filled into the dialyzer and blood compartment. Drain valves are opened and more Renaclin solution is filled into the dialyzer. This test prevents any microbial growth in the dialyzer. Step 6 is the final value appears in the machine screen and a printout of the value may be taken. Thus, we can take a printout how much the fiber bundle volume percentage we will get, and it requires 12 minutes. Most of the machines take 12 minutes to complete the entire process. And after everything, after each shift, the reprocessing machine shall be disinfected by selecting the disinfectant mode in the machine. If we select the disinfectant mode, automatically the machine will disinfect itself. There's a comparison of manual reuse and automated reuse. Manual means needs more manpower, and manual decrease in number of reuses. Human errors can happen. Then we are fiber bundle volume checking any error or anything happen in between, the reuse will decrease. That is the human error will happen for manual reuse. There's a chance of cross infection is there. We are washing together all dialysers, and the water pressure needed only 50 to 20 psi, and FBV also we are checking manually. But in automated machine, it is very easy method and increase the number of reusers, and 2 or more dialyzer can be washed at time, and water pressure is more, 40 psi pressure is needed, and all data management is computerized, data-based management. There's a lesser risk of infection to the dialysis personnel. We no need to manually wash, only put the dialyzer, and after washing we have to take and keep in the dialyzer rack. There's a lesser risk of disinfection to the dialysis personnel. In case of any membrane leak is there, the dialyzer is rejected and thereby prevents the blood loss during dialysis treatment. And then the general aspects of reprocessing dialysers. Hepatitis C patients, we can reuse and in separate reprocessing areas. And usually hepatitis B dialysis should not be reprocessed. And HIV also we can reprocess, but in separate areas. It's safe, but it is used in separate reprocessing areas. The next is single-use dialyzer advantages. This is single-use we are using reduced manpower, no exposure to chemicals used in cleaning and disinfection, pyrogenic reactions can avoided, high dialyzer clearance, efficiency of dialysis will be high because each time we are using new dialysers for that patient. Then efficiency will be high, and there is no chance of transmission of infectious agents and no need of dialyzer storage room. The next one is how to improve our quality or how to improve the reuse. First point is proper dialysers are to be decided by calculating the body surface area of the patient. We are body surface area, we know height into weight divided by 3600. We are calculating body surface area, and dialyzer surface area is 75% of the body surface area. The proper dialyzer surface area should be correct, adequate for proper use. And the proper priming techniques should be followed. We have to prime the tube and dialyzer with only the pump speed of 200 ml per minute. Otherwise, the air will enter and the all air will tap in the dialysers. Then our reuse will decrease. That is why for proper priming techniques should be followed. And heparin line should be washed in 150 ml per minute only. Other lines should washed only in 200 ml per minute. And proper anticoagulation should be followed during treatment. We have to ensure that the proper heparin is given. according to patient's body weight. If body weight is high, we have to give more high dose of heparin for that patient, and that proper anticoagulation should be followed during each treatment. And adequate blood flow should be ensured from the axis. We have to keep 250 to 350 flow from the vascular axis for each treatment, because if flow is 150 only, there's we are seeing the dialyzer or tubings will clot in the during dialysis also, it will get clotted with 150 ml of blood flow. That is why we have to keep 250 to 350 ml per minute blood flow to ensure from the axis to we get reuse, proper reuse. And avoid rinsing, avoid air rinse during termination. Because during termination, as we discussed earlier, we have to return the blood with normal saline, not with air. We have to return the whole blood with normal saline. In some units, the heparinase saline is using for returning. And some centers, after returning, the old tube and dialyzer is put in recirculation with heparinase saline for increased reuse. And better to avoid air rinse during termination. Avoid delay in reprocessing. 2 hours is okay. We have to wash the dialysers and dialysis within 2 hours. After that, it will the fibers all will clot. Then use proper concentration of the disinfectants. We have to use the correct concentration. If DIALYSER or Renalin, we are not using not correct concentration, it will affect our reuse. And we have to follow proper reuse techniques. This much 15 minutes means 15 minutes we have to give washing, reverse disinfection, and proper reuse techniques should be followed for we have to get adequate reuse. Then record keeping. Then we have in every dialysis unit, we have to keep at least the following. One reuse registry is needed for when dialyzer is discarding. We have to mention and write the name and MRD of the patient and the number of reuses in that register. And the next is a manual of reprocessing process. How we are reprocessing the techniques, we are standard operating procedures is there. We have to keep a manual. How is our reuse techniques are going on, that we have to keep. And RO water quality records. Every month we have to check endotoxins and blood water cultures we have to check and recorded in that file. And then MSDS file also key, because material safety data sheet, because all we are dealing with the hydrogen peroxide, Renalin, all are dangerous chemicals. That is why every unit has MSDS file. And the next is KT/V register. We have to keep the all patients URR or KT/V for monitoring the dialysis efficiency, because the dialysis efficiency is decreased due to this reuse. We have to know why the patient is KT/V is less due to this reuse or dialyzer reuse, or any other reason the KT/V is decreasing, that we have to keep a KT/V register for all unit. And the next is training attendance sheets for newly joined dialysis personnel. We have to give proper training for reuse techniques. Some different hospitals follow different techniques, but that is why we have to give proper training for newly joined dialysis technicians or nursing staffs, how dialyzer and blood tubings is reused. The next step, it's a rare chance, as Sir is told, it's a rare chance got infected from a dialyzer, but we have to carefully monitor. For each patient, reuse dialyzer is using means we have to carefully monitor the patient. The greatest hazard facing reprocessing program is the risk of microbial infection due to the inadequate sterilization of the dialyzer. What are the precautions we have to take to reduce infection? Contaminations can happen when washing or by usage contaminated sterilant. Because our sterilant is contaminated, the cans we filled disinfectants we are filling in cans. Then cans has to wash at least weekly once. We have to wash the cans. And monthly once we have to change the cans for avoiding contamination of that cans. And both the compartments, the blood compartments and dialysis compartments are filled with renalin without air bubbles. If we are taking for dialysis, when we taking with priming, if we are feeling that there is a inadequate disinfectant is there in that dialyser, we don't don't use the dialyser for the patient. Sometimes it may improper filling of dialyser renalin or disinfectant will cause pyrogen reactions or contamination reactions to patients. If we are feeling that there is not inadequate disinfectant, then we have to keep and take a new dialyser. And the renal sterilization shall be done at least 11 or 12 hours. At least 12 hours we have to keep the dialyser in rack. Because if today night one patient is dialyzed and we wash, and in between the patient again the doctors is posting for next dialysis, don't take that dialyser, we have to take a new dialyser. If the sterilization should be done at least 12 hours. And the water, RO water used for rinsing and reprocessing must meet AMI standards. The RO water is for reprocessing should meet our standards. The endotoxin discharge and colony forming unit should be less than 100. Ensure the dialyzer and tubing should not use for another patient in any circumstances. There's a mistakes can happen because so many patients, similar names, we can change the dialyzer. Before the dialyzer and tubings priming itself, we have to make sure that the same patient is that dialyzer and tubings is the patient, same patient's dialyzer and tubings we are keeping for priming. Because if changing means we have to discard the whole, and it's a very dangerous issue to that patient. This is carefully do that because similar names, so many patients got similar names. And there's a name alert should write in the dialyzer also, and rack also there's a write name alert. Like this way we can prevent dialyzer infections. Thank you.